had an exciting webinar for all of you tonight. Thank you all for joining us. So good evening and welcome to everyone. My name is Janet Krummis. I'm the chair of the FDA Task Force of Doctors for America, and I am incredibly pleased to welcome you all to this event centered on food safety, regulation, and how this affects our job as clinicians. Before we get started, I want to take a quick minute to invite you to officially join Doctors for America and the DFA fight to improve healthcare for all. We are a movement of now over 40,000 doctors and medical students across the country who have come together since 2009 to ensure that everyone has access to equitable, affordable, high-quality healthcare and the opportunity to lead a healthy life. Becoming a DFA member is easy. Just go to the chat to support DFA's work to improve healthcare with incredible programs like this webinar and our advocacy grand rounds. Today, we will be live streaming the presentation to Facebook Live, as well as recording it, and all materials will be available afterwards. As a reminder for this educational session, we welcome your questions. Please remember to use the Q&A feature on Zoom, and we will address your questions during the second half of our session. And now on to our fabulous speakers. We are thrilled to welcome Dr. Susan Mayne and Dr. Darin Detwiler. Dr. Susan Mayne is an adjunct professor at the Yale School of Public Health and former director of the FDA's Center for Food Safety and Applied Nutrition from 2015 to 2023, where she led major advancements in nutrition and food safety policy, including implementation of the FDA's Food Safety Modernization Act. Prior to her time at the FDA, she spent nearly 30 years at Yale, serving as the CEA Winslow Professor of Epidemiology and holding leadership roles in chronic disease and cancer epidemiology. A widely cited researcher with nearly 250 publications, she has consulted for several national academies, committees, and served 2 terms on the U.S. Food and Nutrition Board. She has a PhD in nutrition sciences from Cornell. In 2024, she received the Conrad A. Elmerham Award for Public Service in Nutrition. Our other speaker, Dr. Darin Detwiler, is a professor, author, and internationally recognized expert in food safety, regulatory policy, and corporate responsibility, with over 30 years' experience advising U.S. and global agencies. He has served on key advisory bodies, including the USDA's National Advisory Committee on Meat and Poultry Inspection and on the FDA Foods Coalition. A frequent keynote speaker and media contributor, Dr. Detwiler's work bridges policy, industry, and public interest. He is the author of Food Safety, Past, Present, and Predictions, and Building the Future of Food Safety, Blockchain and Beyond, and his thought leadership has been featured in major media outlets. He received the 2018 IAFP Distinguished Service Award and the 2022 Ewen C.D. Todd Award for his impact on foodborne illness prevention. And with that, I will turn it over to our speakers.
Okay, thank you. I'm going to go first. I'm Susan Mayne. And I just really want to thank Doctors for America for inviting us to come talk about the food side of FDA and for the advocacy more broadly for FDA. I find that a lot of people really are not as familiar with that. So I'm going to start off with some introductory comments, really explaining how the foods program at FDA works, specific to the human foods program. Next slide, please. So basically, just to start off, FDA has a really big job, and that's because FDA is responsible for assuring the safety and labeling of 80% of the U.S. food supply. And for the most part, that's everything except meat, poultry, catfish, and liquid eggs, which USDA is responsible for. So 80% of the U.S. food supply. And today we're going to talk about food safety. And when I say food safety, most people think about microbial food safety, things like Listeria, E. coli, Salmonella, but it's much broader than that. Food safety includes chemical food safety. You think about chemical contamination in foods. That can be from environmental contamination, that can be process-induced contamination, all kinds of contamination. Allergen controls and labeling, that's a key part of food safety. One of the leading causes of food recalls is undeclared allergens. So food allergy communities, that's a really important one as well. And there's other types of food safety issues as well. Physical contaminants, you may have seen right now, there's a corn dog recall because there's wood particles apparently in the corn dog. So that's something other than microbial chem or allergens. And even radiation. We've had a really unusual recall of shrimp as well as certain spices this past month due to cesium-137 contamination. So even radiation can be a food safety issue as well. Next slide, please. And just to provide a little bit of a context, and you may be more familiar with the Medical Product Center. So this was a slide that FDA gave me. I asked for materials if they would give me current. They gave me one slide, this one right here. And just to highlight a few things, the budget for the Human Foods Program is about $726 million for 2025. And that includes about 1,600 people, in the Human Foods Program. And you can see it's 62% of FDA's foods budget, and that's because FDA is also responsible for animal food. And we have animal food recalls for salmonella that can make people sick. So there's an animal food and a human food side. I'm going to stick to the human food side tonight. It's very different than the medical product centers because almost all of the food side is post-market. That is, people introduce food into the food supply, and FDA's job is to get it off the market if it's unsafe. There is a small pre-market program that is really the food additives and food ingredients, generally recognized as safe program, about 11%. And the last piece of it is user fees. The foods program stands in stark contrast to the medical product centers, and that only 1% of the budget comes from user fees. That pales in comparison to all the other centers at FDA. And where that becomes really important is in times like a shutdown right now, because though we have no user fee positions to support those scientists. So the only ones who can work, and we can get to this later, are those who are working on emergency response type of activities. Next slide, please. So how does FDA oversee a post-market program that's 80% of the US food supply? Much of it is guided by a law that was signed by President Obama in 2011 called the FDA Food Safety Modernization Act, which we also call FSMA. And it really shifted the framework into a prevention-oriented approach. And basically, the law stipulates that industry is responsible for preventing contamination. And there is a series of rules that we had to roll out starting in 2015 to really talk about what industry needs to do and how to prevent that contamination from the farm, including produce growing, in the food manufacturing facilities, when you're transporting food, what foreign suppliers, what their obligations are for food safety. There was a requirement for food traceability and other pieces of the FSMA law as well. It also mandated inspection frequencies for the Human Foods Program, and that basically said that high-risk food facilities need to be inspected every 3 years by an inspector, non-high risk every 5. And it is a massive task because there's approximately 300,000 food manufacturing facilities that FDA is responsible for. About half of that is overseas. States do some of the inspections of these, primarily the non-high-risk food facilities under contract to the FDA. Next slide, please. Another key piece, not just the surveillance piece of it that FDA does, is a huge role in outbreak investigations. And this is a partnership where FDA coordinates with other federal partners, CDC in particular, also USDA, and state partners in investigating multi-state outbreaks. CDC, the states, and the local health departments really get the ball rolling. If you have someone who becomes ill from a foodborne illness, they are the ones who will be doing the patient interviews. They will do clinical sampling, genome analysis of pathogens to try to identify if there's an outbreak cluster. Sometimes FDA will be working with international partners. It was very common for us to be working, especially with Canada, because a lot of the Canadian food supply comes from the US. And we would also often have outbreaks that would span both the US and Canada as well. Once there are some potential food sources that have been identified by those interviews or by other information, FDA's job is to really initiate the trace back and go from the people who reported getting sick. What did they eat? Did they all have anything in common? Did they eat at a common restaurant? And start working your way back through the supply chain to try to figure out what it was that might have made people sick. If FDA has some suspicions, they can go in and do environmental sampling. They can test food manufacturing facilities. They can test foods. And if they find pathogens, they use what's called whole genome sequencing, very similar to what's used in medicine. We use Illumina sequencers at the FDA to sequence the pathogens. And that's really important because if you have the sequence of the pathogens that make people sick, like a molecular fingerprint, you can see if you can find a match for that with the pathogens that you find in a food facility, for example. Next slide, please. And FDA really pioneered the use of whole genome sequencing for outbreak investigations. It's called Genome Tracker. There is a link at the bottom of the slides if you want information on Genome Tracker. And I worked in molecular epidemiology before I came to the FDA. And this is honestly one of the coolest aspects of molecular epidemiology I've ever seen, where you can really precisely link pathogens in food to people who've gotten sick. And as long as you have some epidemiologic support to the genomic data, you can really get to attribution fairly quickly and fairly precisely. And there's a database that's available, and in some cases, people will be sickened and they'll query the database and they say, we've seen this pathogen before and we saw it in this food manufacturing facility. And sometimes you can solve an outbreak just based on the genomic analysis of the pathogen with the then associated epidemiology. Once the FDA knows what the food vehicle or the source would be, consumer advisories, food recalls, you commonly see these in the news, those would ensue to protect consumers. FDA will often go into facilities and do very in-depth inspections, what we would call a root cause inspection, to really try to understand how did the food contamination occur. And the resulting data information is shared with the industry through the prevention plans that FDA issues to really have the goal of preventing future outbreaks. So it's a loop where people get sick, you identify the food, you try to figure out what went wrong, and feed that information back to industry to hopefully prevent those types of outbreaks in the future. Next slide, please. And my last point before I switch it over to my colleague, Dr. Detwiler, is that we're talking about food safety here today. But food safety directly impacts nutrition in lots of really key ways. And the center that I led, the Center for Food Safety and Applied Nutrition, I learned that every single day how closely interrelated these two concepts are. And let me give you just a few examples. When we think about nutrition, we think about fresh produce, try to get people to eat whole, healthy foods. Well, those fresh produce products can be contaminated with microbial contamination, things like E. coli and lettuce. And if we have that, then people aren't going to want to eat them, and that damages our nutrition. Also, a lot of produce comes out of the ground, and it may pick up things like lead or cadmium or arsenic. Things like rice concentrates inorganic arsenic. We've got cadmium in leafy greens. We've got lead in sweet potatoes. These are the kinds of exposures that can contribute to a concern about chemical safety, but these are some of the most nutritious foods we have. So when we're thinking about all that, we have to balance the two together. Some of our healthiest foods, think about dairy products. They are at risk for listeria, campylobacter, other types of microbial contamination. Seafood, really important part of a healthy diet. Seafood concentrates the perfluorinated alkyl substances or PFAS and things like mercury as well. So as we work to get better food safety, it also has ramifications for nutrition. So with that brief introduction, I'm going to turn it over to my colleague, Dr. Detwiler.
Well, thank you very much. And I too thank Doctors for America for focusing on this topic and providing an opportunity to share this information with the participants. I want to start off by sharing that, the foods we look at today when it comes to outbreaks and recalls are kind of different than we looked at in the past. Back in the early 90s, we typically looked at meat and poultry in terms of E. coli and other concerns about foodborne illnesses and outbreaks. Today, we see a great deal more with produce, especially with produce when you look at the fact that there's that phrase, you don't cook your salads. Much of the produce that's out there that is shipped from one state across multiple states often is not tested early and is not cooked. And it becomes problematic not only in the state where it's grown, but in the multiple states where it's distributed. And of course, now we're engaging multiple public health agencies in tracking down that information. We have ready-to-eat foods and commercially packaged goods. And, Dr. Mayne brought up the idea of even dairy and milk. There's a great deal of concern over that balance between the needs and the conceptualizations, the understandings around nutrition and health of raw unpasteurized milk versus pasteurized milk. And of course, the impact on food safety that has had for consumers. We also just talk about restaurants and retail or grocery stores anymore. People are ordering food over apps. They're having food delivered or partially packaged, and you finish cooking it at home, or food trucks. So the way in which people get food today is also complicating the idea of where our food comes from. On a big picture, though, for decades now, the World Health Organization has held that an estimated 600 million people globally fall ill after eating contaminated food, and some 420,000 die every year. In the United States, again, for almost 3 decades, the CDC has held that some 48 million every year, 48 million Americans get sick, 128,000 are hospitalized, and some 3,000 die due to failures in food safety. This is pretty significant. It's also significant that these numbers have not changed even by 1%. And I am always quick to remind audiences that 1% change may seem small, but 1% of 3,000, that's an entire classroom of students, assuming 30 students per average classroom. But we can break it down even more. Whether we look at global statistics or national statistics, we know that there's also certain patterns that we tend to find. Everyone can get sick from a failure in food safety, whether it's that piece of wood in the corn dog, or a wire bristle in a pizza, or chemicals wrongly contaminating it, or allergens wrongly labeled or not prevented, or obviously foodborne pathogens. But it is the most vulnerable consumers, the very young, those who are immunocompromised, those who are pregnant, and those who are elderly, that are the most likely to seek medical attention, to be tested, and to become those who are hospitalized and who die. In fact, I rarely see a listeria outbreak after incident report when the CDC publishes a final report that not only lists a wide range of these patients, victims being amongst these groups, but it also includes that, and many times pregnant women, they may recover, but they will suffer from a stillbirth or miscarriage of that child during that pregnancy, during that illness, in which usually they were trying to eat salad or trying to eat other foods that they were under the impression was a healthier choice for them. I want to talk about this idea of farm to table. We talk about farm to table so much with food. It's like the most common phrase you end up hearing is farm to table, farm to table. I want to talk about it in terms of it being a myth, okay? Yes, it does exist in the sense of marketing and sales. But when you look at it in terms of nutrition, when you look at it in terms of health and safety, it takes on a different aspect. It's not complete. It's like only a small portion of the discussion. The reality is we need to look at the farm to public health reality, the farm to public health nature of food. In most cases, we do not have recalls or outbreaks outbreaks declared unless we have significant data from those people who are impacted by this. It is usually after there's enough information that a company will decide, yes, we're going to do a recall, or that a state health department or even the federal government will say there's an outbreak because of this. If we are not including public health information from hospitals and even from funerals, we do not have the complete set of data that is necessary, not only in terms of issuing a recall or an outbreak, but in terms of preventing them as well. One chief aspect of it is we say foodborne illness, but in many cases, it's not just from eating contaminated food. We have significant history and data that shows that there are people who become sick with a foodborne pathogen, not just from eating the contaminated product, but from hand-to-hand, person-to-person contact, from waterborne exposure, from animal contact, and even in the case of norovirus, from airborne exposure. So again, it kind of expands the real nature of this idea of simply calling it a farm-to-table issue. But I want to put some voices behind all of this. You know, picking up on the idea of where you got it, how you got sick, I've often worked over the last 3 decades with Dr. Philip Tarr out of the Three Rivers area, and he is a significant fixture within the foodborne illness and medical community. And one thing he tells me often is that doctors often make the problem much more worse if they're not focusing on the right thing. The biggest thing he says is they need to test for and treat for a foodborne pathogen. Their biggest concern, a doctor's biggest concern is it's either in the gut or it isn't. Don't start asking questions like, what was the last thing you ate? Where did you go to eat? Things of those, because that is never usually the source of the contamination. He actually has told me that he sees more cases of E. coli from waterborne exposure than he sees from food. But when people start to ask questions and start thinking about what was the last food you ate, it throws off the conversation with the health department, the public health experts who are trying to collect data to find those connections to figure out where this came from. There's also the idea of understanding the full clinical trajectory of E. coli, other pathogens, and their complications, such as hemolytic uremic syndrome. This is a young boy who became sick with E. coli. It was progressed such that he was hospitalized. He had hemolytic uremic syndrome. He was on dialysis. And during dialysis, he ended up having a stroke and losing the use of one of his arms. Understanding through early detection and monitoring, these are key steps in terms of preventing severe long-term disabilities. I mentioned misdiagnosis before. Early mixed diagnoses here with this patient, by the way, she was a university junior at the time. They thought it was appendicitis, then they thought it was a virus, and then they sent her home. She started to hemorrhage. She came back, ended up spending 3 weeks in and out of 2 hospitals, 2 emergency rooms, and 3 urgent treatment facilities, losing nearly 20 pounds before someone decided to test her for a pathogen and find out that it was E. coli. She spent the next 5 months in recovery and on continuous antibiotics and vitamins from the resulting complications. Even for months after her discharge, she was unable to feed or care for herself, and it took several months before she was able to walk again. By the way, she got this from a salad in 2006, E. coli and contaminated spinach salad. This 4-year-old girl from the Portland, Oregon area, 4 years old with bloody diarrhea, and her father was taking her to an urgent care to see a doctor, texted his brother the symptoms, and the brother texted back, you should test for, ask the doctors to test for E. coli. Doctor took a look at her and suggested that, you know what, she's probably eaten something. She didn't agree with it. Keep her hydrated, work on getting her more fluids, and make sure to follow up with her family doctor within a week, and sent her home. Well, she was dead within 3 days, unable to see her family doctor because she was actually in an earlier stage of renal failure. And yet the investigation found that the nurse wrote E. coli question mark on the intake forms. Yet the doctor sent this young girl home with bloody diarrhea. Again, the idea of most vulnerable consumers. And in this case, a 4-year-old girl, definitely most vulnerable. Her family urged the state legislature in Oregon to look at the idea of mandating that doctors who see patients who fall into the most vulnerable consumer categories if they show symptoms that are aligned with potential foodborne pathogen, that they are required to test for a foodborne pathogen. That unfortunately did not receive enough political support. Finally, the idea of, again, I mentioned that you don't only get a foodborne pathogen from eating a contaminated product. In 1993, young 16-month-old Riley got sick from another classmate in person-to-person contact. And at first, it was not seemed to be like this is part of that outbreak. Well, the testing, all the evidence showed that it was 100% part of that outbreak. And Riley died within a month of showing his first symptoms. And yet the person he got sick from was 2 months older, was never in the hospital. So no two patients are alike. No two patients, especially when they're more vulnerable, their immune systems are not alike. You need to treat every victim as if this could be, nothing simple to deal with, but this could be a terminal life-threatening illness for them. By the way, Riley there, the child on the bottom right, was my son. And in 1993, I learned about E. coli on my son's deathbed. And that is a place where no parent should learn about E. coli or food safety concerns, foodborne pathogens. But I've learned something along the way. I used to think for a long time that there were two categories of victims, those who survived and those who did not survive. But what I've come to learn through so many families that I've worked with over the years is that in between those is another category, those who are discharged from the hospital, but not from the true burden of the disease. There are so many victims who will live with forever symptoms, forever fears, with quality of life that is never the same as it was before their illness, but technically they're discharged from the hospital. These are people who will live with early onset adult arthritis, with cognitive delays, with physical disabilities. I know some who they will never have a cognitive ability greater than the 2-year-old age they were at the time they got sick. They will never have the experience life as a teenager or live on their own. So we have to realize that, again, there are people who focus on the idea of survival, but survival and recovery are not necessarily the same. I hope this helps put a bit of a face and some insight into the idea of just how important it is, not only for the clinical physician's role, the doctor's role in the heat of the moment there with the patient, but how important this information is to make sure that it is reported, that testing is conducted, and that there's information and data provided to people who can now find out what was the cause of it and try to put the cause to an end as soon as humanly possible. I'm going to turn it back over to Susan for a last couple slides.
Great, thank you, Dr. Detwiler. So a few comments. I know that part of my role here was to talk a little bit about advocacy. And one of the things I wanted to start off by saying is that consumers nearly unanimously think that keeping our food supply safe is a federal government's job. It's not controversial. The federal government has an enormously important role to play, and so do state and local governments as well. So we need to support that, and we need to make sure that they can do their job. And one of the myths I've heard many times with the layoffs and some of the resource cuts at the FDA is that the FDA has become bloated and they've gotten so huge, and they used to be some size in the past and now they've gotten so much bigger. That's true on the medical product sides because of user fees. They've been able to hire additional folks in the medical product centers to review all of those new drug applications so industry can bring their products to market in a timely fashion. That is not true in the Human Foods Program. And this is a graphic that I pulled from the Reagan-Udall Foundation report that was published in 2023 about the Human Foods Program. And what you can see is that in 1978, the center, which was the center that I led, had about 1,000 people. And it wasn't until we got into about 2020 that we barely exceeded that, despite putting a massive legislative burden on the FDA to implement the Federal Food Safety Modernization Act. And so you've seen it bounce around a little bit over time, but it has not become bloated. And the other thing that's changed is the scope of the work they have to do has increased just exponentially. So many products coming in from overseas, so many complicated products, things like gene-edited crops FDA is responsible for, or cell-cultured meat, things like infant formula, with human bioactives, all kinds of things FDA is responsible for. So the complexity, the number of products, and the number of import lines has greatly increased over this window of time. And I just put in there for comparison, USDA is responsible for approximately 20% of the US food supply. They actually have more resources for their 20% than FDA has for the 80% of the food supply. Next slide, please. And on top of that, there have been some challenges coming in based upon some decisions made in the current administration that I thought I'd briefly highlight. And I just put this together as a top of mind, a few of the things that I'm concerned about. The first one is employee losses. We've lost all kinds of scientists. We've lost investigators. ProPublica has estimated about 20% loss investigators. I'm still seeing people leaving the FDA, so we're losing people. The leader of the Human Foods Program resigned after the Trump administration came into being, saying that he wanted to build a chemical safety program, and they fired all of his probationary people that he had just brought on to do chemical safety in the foods program. They've also disbanded a really important advisory committee called the National Advisory Committee on Microbiological Criteria in Food. And we used this advisory committee to really to do a deep dive where we needed more science. And one of the charges that I gave to the NACMF committee was to really look at Cronobacter. This is a bacteria we really didn't know much about until it contaminated infant formula that led to the infant formula recalls that we experienced post-COVID and shortages. That was due to Cronobacter contamination. So this committee had been studying this issue for 2 years to better advise how to prevent Cronobacter contamination in powdered infant formula. The report has never been released because the committee was disbanded before they could release it. A really important foundational rule that FDA was required to do by Congress is the food traceability rule. The compliance date for industry was set for the beginning of 2026. And when the Trump administration came in, they delayed the compliance date by 30 months. And in my time at the FDA, I never saw any rule delayed by 30 months. This is unprecedented. So now industry doesn't need to comply for another 2.5 years until essentially the end of the administration. There was also a really important rule that USDA had worked on to try to address the problem of salmonella contamination in raw poultry. It was proposed during the Biden administration. Under the Trump administration, they withdrew that proposed rule. They've also taken hits to the surveillance system that we had in the US called FoodNet. Used to have surveillance for 8 different pathogens, and they said due to lack of resources, they are no longer doing US surveillance. They use 10 states as kind of to estimate what's happening around the United States. Now they're down to 2. And so that means for those 6 other pathogens, first time in 30 years, we will not have any data to look at what's happening in trends in some of these pathogens. It means the federal agencies can't prioritize, they can't do risk-based budgeting and prioritize their work because we won't have the data to do that. EPA has also rolled back.
Hold on, can I add
Yeah.
on that bullet point there?
Yeah, go
I
ahead.
had a conversation with the reality of that, cutting 6 out of 8 pathogens in FoodNet surveillance. And one of the concerns is that there are industries or food manufacturers or food companies out there that there may be some that will continue to test for some of those pathogens, but now there are companies who are like, why do we even bother to test for those things if they're not even part of what's being surveilled? So there's political decisions that have industry impact because of priorities as such.
And just a few more. One of the issues is environmental contamination of food, which is supposed to be a priority of the Make America Healthy Again movement. But what we've seen is big rollbacks of many of EPA's environmental standards, including one that I worked on in my time at the FDA, which was food that was contaminated with the PFAS substances. And PFAS gets into the water, it gets into the soil, it gets into seafood, it gets into produce. And the only way to really address it is to avoid the environmental contamination, but we've seen rollbacks on that as well. Interestingly, recent surveys, and this is from multiple sources, IFIC, Gallup, others, are showing that consumer confidence in food safety in the US is now at a historic low. I'm personally, we keep seeing more and more and more recalls, and quite a few deaths recently. So definitely, I'm concerned. I remain concerned. And now we put a government shutdown on that. And I led through the 35-day government shutdown, the Center for Food Safety and Applied Nutrition. And at that point in time, and there are laws that say who can work during a government shutdown and who cannot. It's called the Anti-Deficiency Act. And the employee's job must be critical for life and safety for them to continue to work. So that means all the food testing and the sampling does not go on. It means the food additive reviews do not go on. It means the routine surveillance inspections do not go on. All the nutrition work doesn't happen. So there's just an enormous, lack of activity. I would say probably about 80+% of my employees were on furlough at the Center for Food Safety and Applied Nutrition. And so that's where we are right now. That's going to make it really hard for them to get through those 300,000 food manufacturing facilities if this shutdown continues for a lengthy period of time. So I think advocacy is important because we're facing more challenges in food safety than we've ever had before. And so I'm really pleased that Doctors for America has taken a stand about advocating for FDA and for USDA. They are critical pieces of our public health system. And again, consumers think that the government has an essential role to play in assuring the safety of food. So those are my final remarks. So we hope to leave, and we have, I think, left some time for questions. So I'm going to turn it back to our host, Janet, and maybe you can lead Q&A for us.
Thank you so much for a compelling presentation, but I think it also makes that sense of urgency, very real for all of us. There are many things that we're concerned about, but in terms of what touches us day to day, in terms of our clinical practice, I don't think anything is as important as food safety. Could you speak for a moment to the impact on cuts at your sister federal agencies with whom you had to work closely? For instance, with the CDC, you successfully got Chronobacter, a notifiable disease. What is going to happen without that interagency cooperation?
Yeah, and I think, I'll say two things. First is that, we worked so closely with the other federal partners that you knew immediately who to call. I was on phone calls with USDA almost every day. I knew all the leadership at CDC. We worked very closely together, and then everything gets disrupted. And, there's been proposed reorgs, there's been closures. Some of the infectious disease folks at CDC have lost their positions. So you've broken a collaborative network that knew how to work together. So that would be the first thing. The second thing is you've got people who are on furlough, not necessarily for the outbreak team. They should be able to work because if they're working on an outbreak, that meets the criteria for being able to work, being accepted from the furlough. But, it's tough right now. It is very tough right now. And I would say the same thing is true for USDA. They've lost a lot of people. NIH is losing people as well. And so those were the major collaborators that we worked with. And so that certainly has ramifications. I'd say the other piece of it is that FDA worked very closely with the World Health Organization. When we set standards for things like chemicals in foods, that is through a process called Codex. And so FDA works very closely with WHO and the global community because our food supply is global. So if we can set global food safety standards for things like lead in food, then that's going to help assure that the US food supply is as safe as possible. And so as in the last Trump administration, we had to exit WHO, which certainly provided some complexities to our ability to work on global food safety with our international partners. So you are correct, it makes for a much more challenging system when people are gone and new divisions are put in place who've never worked with us before. And so that can be very challenging.
And I would assume, and this is a question for both of you, that particularly with the foodborne pathogens, the numbers we're seeing are really the tip of the iceberg. So I guess the question is, how do you think the best way forward, for instance, for us to advocate for the Human Foods Program and for increased surveillance? How do we make that point to our legislators in a way that actually gets through the noise?
Darin?
You know, I have to admit, one of the things that I talk about a great deal as an example is the whole idea of the doctors that supported the idea that newborns needed to have approved car seats when they are, leaving the hospital to be taken home for the first time. Doctors who are looking at the rates and the incidence of not only injury but even deaths to newborns who were literally being held by their mother on the lap in the front seat of a car back in that time, and drawing the line and saying, look, enough is enough. How can we send them home in these conditions? Let's not only support this, let's raise the funds if they can't afford the car seats. Let's make it such that the law says that you do this. There's ample evidence and examples of doctors saying that we understand the impact on public health when there is a gap here. Let's work to support this. And the craziest thing is that, that was something that's very specific to a family that has a newborn child, right? Food applies to everyone, every family. It doesn't matter what state you're from. It doesn't matter your social economic status. Literally, there is zero discrimination when it comes to foodborne pathogens and failures. Everyone is susceptible to this. Every health issue, every treatment, every dietary concern is either supported by or ruined when we don't have safe food to start with. So the idea of understanding these numbers and realizing that, it's almost as if there's three different speeds of wheels going on, right? The consumer behavior will change rather quickly. Industry change will be a little slow, but politically, that's the slowest wheel of change. A lot of these policies that Dr. Mayne mentioned, they went away overnight. They took years and decades to get through Congress, to get written, to get passed, to get implemented. The Food Safety Modernization Act took multiple attempts and multiple years just to get passed, and then multiple years to get the rules written, and then multiple years for implementation. We started technically working on the produce safety back in 2006. FSMA, one of the main rules is produce safety, was passed in 2010, signed into law 2011. Implementation started in 2016. We're still dealing with delays this year in water testing and treatment for produce. So again, the wheels move very slowly in the political sector, but I think that within the medical community, there's a great opportunity, whether it is, educating or advocating or just being that voice that says, oh, and by the way, you need to consider this. You need to consider this with your family right now.
Yeah, and I think there's an opportunity as well with Make America Healthy Again, because how do we make America healthy again if we have unsafe produce or we have unsafe seafood or, the things that are literally the foundation of our dietary guidelines? I think we all know that the dietary guidelines are going to be coming out again. They've already signaled the importance of whole, healthy foods, and you can be assured that's going to be fruits and vegetables. But how do we make sure they're safe so people will eat them? You heard us both talk about leafy greens. We've all lived through some of those outbreaks, and It's very challenging. I've heard people say to me, I'd rather eat a bag of Doritos than a salad because I won't get E. coli from it. And we just can't have that. So how do we make America healthy again if we don't have safe food? So I think really, really highlighting that as well.
And actually, that speaks to exactly what I was going to ask you, is whether you see any glimmers of hope from Secretary Kennedy's platform and desires and goals. I mean, I think there initially was a little bit of optimism that in some areas there would be uh, places where we could work together and we could really make progress. Are you hearing anything that suggests that there are areas where progress and patient care and standards are actually advancing and not?
My answer is no. And I actually have an article coming out in JAMA Health Forum in about 9 days where I talk about that. I think the problem from my perspective is that there's laudable goals, including in the MAHA strategy. They've got the problem identification, they've got the goals, get healthy food into the people who need it most. But then they cut SNAP by, unbelievable amounts of money, the biggest SNAP cuts in history. They said we need to get people eating healthier, and SNAP education is now terminated. It was the way to help educate people on how to use those limited resources and eat healthy. So same thing with the ultra processed food stories and the high sugar, high fat, high sodium foods. Basically, the administration is deregulatory in nature, and they don't want to regulate any of the things that I would really prefer to see done. I think we need to take action on too much sodium in our food supply, as we've been doing for the last several years successfully. But that seems to have been just put off for the future. Even taking action on sugar, instead of taking action on sugar, which we know is a cause of metabolic harm across the age spectrum, they're taking action on synthetic dyes that draw children to high sugar foods, but the metabolic harm is really from the sugar. So I'm not optimistic based upon what I have seen in the current, initiatives around nutrition and health.
I would also add that, there was some initial conversation around ultra and highly processed foods. I haven't heard any follow up on that, but that category of foods has a significant impact not only on nutrition but on food safety as well. And then we started talking about artificial dyes and colorants and flavorings, and some quick decisions were made. And then we had a pattern where we downplayed the science, downplayed the data, downplayed the facts. If you want to have significant change and you're going to make change, you have to have not only clear justification, but a clear, accepted way of communicating not only the justification for the change, but how you're going to go about making the change. If you want the industry, if you want global stakeholders, if you want the medical industry to support some of these changes, you have to be able to show that evidence and show that you went through the work. We went through the steps to validate all these different things. This is transparency. And we have not seen enough of that, I don't believe.
And the other piece, Darin, I'll add is, there's a really important part of public comment. And part of the importance there is making sure that there aren't unintended consequences. And if you take the example of the synthetic dyes, there are numerous potential unintended consequences that may occur. And there was no public comment. There was no scientific rationale. It was just an announcement. And so that concerns me. I'll just give you one. They're trying to encourage the use of so-called natural colors. These are things that primarily grow out of the ground, where they can pick up lead, they can pick up cadmium, they can pick up the same contaminants. And what the food industry says is they have to use about 10 times as much to get the same intensity of color. So you may well have much higher levels of lead in children's foods that are using these so-called natural colorants. Some of them have allergenicity concerns, and so the food allergy community is quite concerned that that has not been studied in many of these products. And so there's just a whole host of potential unintended consequences that have not been really revealed because there has been no public comment to really look at that. And as a regulator, as a former regulator, you really need to know if you're going to take a step that you're not causing some other thing to be made worse through unintended consequences.
Yeah, that it is certainly a problem. And with the elimination, I think the foremost laboratory at the NIH on ultra-processed foods, led by Dr. Kevin Hall, his laboratory was just disbanded. So the lack of data to support our opinions is what we're seeing as a universal problem, that the data gathering apparatus is being impacted upon, which makes it more difficult to do a fact-based argument in favor of policy changes. Well, that but do you see any groundswell? There's been, some evolution of a thought on the public in terms of what they want as healthy foods. Do you think that there's any group within the MAHA group and broader than the MAHA coalition of people that can be tapped into to support policy changes that will make our food supply safer?
I'm trying. There's a group that runs a podcast that talks about trust. I know trust is part of what you're in as well. It's called Why Should I Trust You? And it actually brings together some of the MAHA supporters and some of the leaders in the MAHA movement, along with scientists and public health people, to really talk through some of these issues. And I have been on one of their podcasts and am willing to try to build that type of trust and say, look, we have the same goals in mind, and let's see how we can work together. I have a lot of experience after 8.5 years in Washington that could help in terms of really making positive change. So I'm trying, others are trying as well, but it's daunting because of this issue of trust. And so if the messaging is coming from a MAHA supporter, they will believe that over if the messaging is coming from public health. And so this is something we're seeing across the medical ecosystem. And so how do we change that so that we can get more trust in our science and our public health messaging?
And
I'll just
oh, please go
I
ahead.
was just going to add that it's sad that the consumers that are most likely, again, to be hospitalized and to be living with lifelong medical complications or to die are, for the most part, the ones who are the least able to participate politically. The healthy American adult who is voting and is determining if they're red or blue or this candidate or that candidate or whatever is amongst the population that typically does not bear the brunt of the true burden of disease. When you're talking about our very young, our very elderly, those with compromised immune system, those who are pregnant, they are not necessarily the ones who have the louder voice. And it is a imbalance of power, if you will, when you look at how with food safety becomes political, that's great for talking points and perhaps with constituency and elections. Not so great when it comes to the idea that families that are struggling with their child in children's hospital and they're looking for support, they're looking for answers, and they get nowhere. And it's been like this for a very long time. It's not just this administration, but the idea that back in 1993, I thought that we would find some political and some scientific solutions for this. These numbers really haven't changed. We continue to find, I believe that the policies and sciences and the medical community has done a great job in reducing these numbers. I think that the nature of how food is prepared today, how food is sourced from multiple countries, and how we have so much more in terms of ready-to-eat commercially packaged goods with 175 ingredients or whatever, and we have things delivered from third-party, delivery and shoppers and all these different things. The complexity of the landscape has somehow counterbalanced all the changes we've made over the last 3 decades, and that's my best explanation as to why these numbers have not changed. The problem I see is that we're only going to continue to see changes in behavior from the industry, changes in behavior from the consumer, changes in preferences, changes in technology, highly processed foods, things of that nature. We're already seeing it. Like, well, you should be consuming food with more protein. Well, you go to Costco and most high protein food is highly processed. So where is that communication and understanding in terms of this is good, however, right? It seems to be a common element that I've seen again over the last 3 decades. And I think that the medical community really needs to continue their role in terms of really advising their patients, advising their families, having information, whether it's, here's a link or here's a brochure, whatever it is, or saying, hey, you just had this surgery, maybe you need to consider this, or, this person in your family just had this medical treatment. Maybe you need to think about this in your household, kind of a thing. Here's some information. Those pieces of information, that advice is the best kind of advocacy that I could possibly ever hope from Doctors for America. Is that there's the advocacy that goes towards the political side, but I think that the biggest impact could be the advocacy that goes to their patients.
And I think that you did two very important things tonight. One is the demonstration that we as physicians aren't always thinking about the different ways that people can become ill that are related to food, whether it is indirect through water. And so I think that heightened appreciation, might send that light bulb off, whether someone is working in the emergency room or seeing someone as an outpatient. But the other very important thing that you did was the use of stories. And we know ourselves that when we're talking to patients, when we're talking to legislators, it's stories that grab people and make them remember what we're saying. So I would ask all of our members who are tuning in and will watch this webinar in the future to, collect those stories, send them to us, use them when you come to our fly-ins, as illustrations of the real effect of policy on the quality of human lives, because legislators do care what happens to their constituents. And I think as our patients hear us best when we can tell a relatable story and when we're open to a broad differential diagnosis, that means that we're hearing them and understanding their problem. So I would like to close this session by thanking both of you so much. We're, eternally grateful for your presentation tonight, which was engaging and clear, and I think will stay with us for a long time and influence how we approach this problem so that we can incorporate this piece into our advocacy work. And to all of our members and people who are potential members out there who are watching, thank you for being here, for taking some of your valuable time to spend an hour with us and hear about an important topic. We hope that you will become an official DFA member today. The number one reason that doctors and medical students join DFA is to be with like-minded people. People who are also passionate about putting patients over politics, making a difference in the world, and making sure that, what we do in the exam room is right, but, we're the ones who are the experts in terms of what happens when you implement policy, what happens at that ground level. So if you can look in our chat, you'll see a very quick link. You can go to doctorsforamerica.org and join us there. But we look forward to seeing you in future discussions. And again, thank you very much, Susan and Darin, for a wonderful evening. I do feel more inspired, and that's why I love this job. It's to get that impetus to find another way to make a difference. So thank you so very much.
Thank you.
Thank you.
And good night, everyone. Stay safe.